Good morning. I'm Al Charbonneau, Executive Director of the Rhode Island Business Group on Health. Thank you for joining us this morning virtually in this important employer event to discuss the question of affordability of commercial health insurance. That is, what can be done to make commercial health insurance more affordable in Rhode Island, and to hear and respond to Neil Steinberg's presentation of the recommendations from the Integrated Academic Health System Community Input Committee, a Rhode Island Foundation report on the proposed merger of Lifespan and Care New England and the establishment of an integrated academic health system here in Rhode Island. I'd like to begin by thanking our sponsors who support Rhode Island Business Group's work, including this morning's discussion. I know I speak on behalf of the RIBGH board and our members when I say I'm truly grateful to our platinum sponsor, Mercer, our gold sponsors, Blue Cross and Blue Shield of Rhode Island, HILB New England, United Healthcare, Neighborhood Health Plan, Tufts Health Plan, and Aetna. Our silver sponsors, USI Insurance Services, Merck, Novo Nordisk, Delta Dental. We are also thankful to our RIBGH members, a growing group of 90 plus companies representing over 80,000 employees. I'd also like to thank Neighborhood Health Plan of Rhode Island for sponsoring today's event. NHPRI over the last 27 years has grown from serving its first 1,490 members in 1994 to approximately 200,000 members in 2021, with revenues totaling almost $1.4 billion. I know Peter Marino would want me to give a special shout out to Elizabeth McLean, Vice President for Commercial Products at NHPRI, who was recently recognized as one of modern healthcare's top 25 emerging leaders in 2021. Quite an honor and well-deserved by Liz. Before introducing today's panelists, I'd like to note in the interest of time, we only do brief introduction. Panelist bios will be on the website along with a recording of this event. It is now my pleasure to introduce our panelists for today, beginning with Kristin Lewis, who's the Chief Government and Community Affairs Officer from Point 32 Health. That is a new company combining Tufts Health Plan and Harvard Pilgrim Health. Martha Wofford, who is the President and CEO of Blue Cross and Blue Shield of Rhode Island and our newest CEO in the community. Peter Marino, President of Neighborhood Health Plan. Don Nokes, President and co-founder of NetCenergy. Sam Salganik, Executive Director of the Rhode Island Parent Information Network. And last but not least, Patrick Tyge, Rhode Island Health Insurance Commissioner. One of the major goals of the Rhode Island Business Group on Health is to stimulate an ongoing focus on affordability of commercial health insurance premiums. We've done that by gaining a seat at the table, at the healthcare reform table here in Rhode Island, by asking the Office of the Health Insurance Commissioner to making affordability a standing agenda item on the OHIC Advisory Council, by asking that affordability be recognized in the Rhode Island Foundation's long-term healthcare plan working group, and that there be a subcommittee on waste and affordability, by raising the question of affordability within the ongoing payment reform discussions here in Rhode Island, and by presenting a data-driven straw man, or perhaps more politically correct straw person, proposals on affordability throughout the state. We are offering the following straw person, not to beat a point to death, proposal on how we should deal with achieving affordability going forward. I'll now share my screen and begin. Here we go. Thank you for being patient. The reason why we focus on affordability is because we're just gonna, there we go. The reason why we focus on affordability, what called our attention to affordability, is the question of what's its impact been on median household income. This slide, which was developed by Ezekiel Emanuel, formerly MD, PhD, formerly of the Obama administration, now I think at the University of Pennsylvania, calculated this kind of a metric because he thought that there was a need to begin to call attention to what the impact is of premiums on median household income. And here in the state of Rhode Island, you can see that in 2019, average family premiums as recorded by the Medical Expenditure Panel Survey were approximately almost 29% of median household income. I'm not actually fond of this particular metric because I think it ignores employers' contribution to premiums, but I can assure you when we incorporate employer contributions into that metric, it's still a very sizable amount of money that is consumed by average family premiums. Secondly, and equally importantly, several years ago now, the Office of the Health Insurance Commissioner called together a group to really look at the decline in small group covered lives here in the state of Rhode Island. Between 2010 and 2019, according to National Association of Insurance Commissioner data, small group covered lives are down by 50%. I brought in large group metrics to the discussion, and large group metrics or covered lives are down by 33%. I don't think we ever got to the final discussion of what the cause of this is. We think there are a variety of things going on, but I think there was general consensus within the group that the cost of healthcare was a major contributor to this factor. And the RAND Corporation has done some research on this. This is a metric that has been used on occasion up in Massachusetts by the Massachusetts Health Policy Commission. And all it's basically doing is taking median household income and subtracting the employee share of family premiums. And as you can see, we start off in 2008 with a median household income of somewhere in the neighborhood of $60,000. And for the succeeding 4 or 5 years, it's having a tremendous impact in median household income. If you look at the changes between 2008 and 2019, deductibles have gone up almost 84%, while median household income has gone up approximately 11%. RAND makes the point when they do this kind of analysis that this means there is less money available for not only for the family, but for use on Main Street, that the healthcare system is competing in effect with Main Street for its share of median household income. So we've started to drill down, and with the help of the Office of the Health Insurance Commissioner and anyone else, and by the way, I would say people in the insurer, members of Rhode Island Business Group, and anyone else that'll listen to me, we've begun to put together, using the data, a way of dialoguing here in the community about what's actually going on. And this is a composite of all large and small group commercial expenses, medical expenses, commercial expenses, including admin, per covered life between 2010 and 2019. The 5 categories are underwriting gain of the insurers, total general and administrative of the insurers, claims adjustment expenses of the insurers, prescription drugs, and incurred claims excluding prescription drugs. Source of the data is the National Insurance, the Association of Insurance Commissioners. And you can see that the blue and the red consume a substantial portion of total expenses here in the state. And what we've found here is to say that while we think everyone needs to contribute to controlling expenses associated with commercial premiums, the largest bucket in these expenses is, of course, coming from the delivery system. And further drilling down, this is a composite of Rhode Island large and small group medical expenses per member per month, covered by commercial premiums between 2010 and 2020. And you can see that there are 5 buckets: blue, total hospital, red is specialist, green is RX, the purple, I suppose it is primary care, and the light blue is other. And my feeling with respect to looking at this is that there are really a couple takeaways. First of all, hospital costs are the largest dollar amount covered by commercial premiums in any given year, and year-over-year change that particular truth holds. RX is the most rapidly rising, and we can look at RX and see some very good drugs coming down the pipe, but that have huge price tags associated with them. So it says to me that we need to impact big ticket items to achieve affordability here in the state. And it's hard in my mind to walk away from the discussion of hospital costs, which is one of the reasons why I think the dialogue at the second half of this meeting about the integrated academic center is most appropriate. But not to ignore taxes, fees, and assessments. Here in the state, if you look at National Association of Insurance Commissioner data, what you find is that with respect to taxes, fees, and assessments that are reported to the NAIC, we have, I think it's the third or fourth largest amount of taxes, fees, and assessment in the country. And that is of concern, obviously, because taxes, fees, and assessments contribute to the cost of premiums. When you look at the upper category here on this slide, there is a hospital tax in Rhode Island, which is not reported to the National Association of Insurance Commissioners, but is paid for by people who buy commercial premiums. And if you total that amount, it's approximately $54 million. That is taxes, fees, and assessments, and those taxes not reported to the NAIC. When I look at that, and if you look at the bottom part of this slide, taxes, fees, and assessments expressed as a percent of large and small group premium is approximately 5%. Now, in 2013, the Office of the Health Insurance Commissioner did a study on mandated benefits. And they came to the conclusion, if I'm correct, that mandated benefits represented 13% of premium. A lot of people feel that there are mandated benefits that are mandated that are good. And I wouldn't dispute that. The point I would want to make is that if the benefit, which lots of times people will say we're mandating this benefit because it will lower cost. Let's just assume for a minute that it does. But if it does not lower cost in the same year that we're incurring the expense of that mandated benefit, then frankly, it's raising premiums. I think the important takeaway message from this particular slide is that state government certainly contributes to the cost of health insurance premiums, and both the General Assembly, the administration, and whoever else contributes to that should be mindful of that. We did have a proposal in the state legislature for what is called a mandated benefit statement of intent. That is a document that's filed every time there is a proposal that might increase commercial premiums. We've yet to see, and it may have been filed and we're not aware of it, but we've yet to see it actually happen. And several months ago, we actually approached the General Assembly to do a moratorium on mandated benefits. Both, by the way, were not successful. So I hope as I offer this for the consideration of the panelists that you understand that what we're trying to say is what will drive the change necessary to make health insurance, commercial health insurance, affordable here in the state. And I offer the following. One is that a genuine focus on affordability. And when I say a genuine focus on affordability, what I mean is that we actually drill down to the granular level. If we think, for example, that hospital costs are having an impact, they may only be going up a small amount, but the dollar amount is large, then we ought to be focusing on that in a sustained way, and we should be data driven. There are, perfect is the enemy of good enough is one of the phrases that I learned when I first got interested in healthcare reform. And there are plenty of accurate data across the state right now, data that's been either there or made available by OHIC that we could use to begin to drive a meaningful discussion on what I would call payment reform. And the reason why I talk about meaningful payment reform is there are a lot of forms of payment reform where we call them value-based payment reform, but the underpinning of some of these efforts is fee for service. And so we're looking for meaningful payment reform that's non-fee for service. So I should be very clear about that. And finally, public accountability. And I'll have to say in the latter part of my career, I had the opportunity of dealing with some very large companies when they were large companies, Xerox, Kodak, Bausch and Lomb. And when I went over to those companies, frankly, I thought that we really had a command of the numbers coming from the hospital world. We spent a lot of time with the numbers, trying to figure out how to make our budget work. But the takeaway from Kodak, Xerox, and Bausch back in the day was that they really sweat the numbers. That senior management was totally aware of what their contribution to shareholder value was. And I would hope that we would come out of this discussion and go forward to the point where senior management and the delivery system is as aware of affordability issues as senior management and publicly traded companies are aware of shareholder value. So with that, I will stop the share. Have I done that correctly, Dana? I guess I have.
You're good.
So let's begin with the panel discussion. Patrick, I'm going to, since I introduced you last, I believe I'm going to put you first. What are the most significant changes in the market do you believe we need to see to make more sustained and meaningful progress on affordability?
Sure. So first of all, thanks, Al, so much, and to the Business Group on Health for having me and all my colleagues here today. It's really, really great to be a part of a forum like this, and especially with these colleagues that are all here today, and really appreciate, Al, you facilitating this. So to answer your question in terms of the most important things, I think when I reflect on the data that you presented, the first thing I would just observe as a baseline is I think what the data clearly shows is that while certainly our efforts in the state on affordability over the past decade plus, we certainly have made progress. There are important, strong foundations the Rhode Island healthcare system has. It's been extraordinarily resilient based on the efforts of many people, both in the system and in government, particularly even over the course of the COVID-19 pandemic. But what the data you showed really makes clear is that we have a lot more work to do. Employers and consumers, first and foremost, are bearing the brunt of the continued lack of widespread and sustainable affordability in the Rhode Island healthcare system and in the Rhode Island healthcare market. And so what I would observe about that in summary is that, at the end of the day, health insurance is expensive because the cost of healthcare is expensive. And what I mean by that is the fundamental drivers, right, are simply, in the most simple terms, are price and volume. The price of the services paid on a unit basis and the number of services delivered, as I think we all appreciate. But of those two factors, price is far and away the greater driver, both here in Rhode Island and nationally when we look at the whole system. So that leads us to what are the most important things, as you're asking, that we can do. And so from my perspective at the Office of the Health Insurance Commissioner, where we're trying to look at the system as a whole and think about what do we need to do to pursue these important public interest objectives of access, quality, and affordability. And I think it really, in my mind, comes down to two things. Certainly not only these two things, but I would highlight these two as the most important. The first is, again, that we directly address price. And so some examples of ways that we can do that. One point that I think is important here is looking at pharmaceutical prices. Certainly, federal action is the most probably important policy action that can happen on pharmaceutical prices. We see how much those are a driver in making care unaffordable for both employers and consumers. And so thinking about things like reference pricing approaches, where we tie the price paid for prescription drugs to international benchmarks that are much more affordable, I think that's a really important measure to continue to look at and try to move forward with, or even looking at things like assessments on unaffordable price increases by pharmaceutical companies. These are all really hard things, but I think they're really important, and we just can't ignore the significant driver that prescription drug price growth is causing in the system. Another example of price growth that I think we have to really continue to look at is, as I think people widely appreciate, OHIC places caps on hospital inpatient and outpatient price growth. It's been observed nationally by publications like Health Affairs as being probably one of the most significant measures to constrain healthcare costs and further affordability for consumers and employers in the country. We have to double down on that and ensure we continue to ensure that hospital price growth only grows at a rate that is sustainable and leads to greater affordability. And then finally, I think here, and we'll probably have a larger conversation about this as the day goes on here this morning, is we really have to think about how do we accelerate our transition to advanced value-based payment in the system. Because I think our fee-for-service system is widely acknowledged, again, both here in Rhode Island and nationally, as being a very significant driver, not only of unaffordable care, but also of low quality care. And we want to make sure, I think, when we're always talking about affordability, that we're also talking about quality and achieving quality outcomes for the consumers who are seeking their care through the healthcare system. And I think payment approaches like hospital global budgets, like primary care capitation, like episode-based payments, all of those, I think, hold the promise, if implemented properly, to create more affordability in the system, reduce the volume incentives that don't serve patients well, that are inherent in the fee-for-service system, and ultimately produce a more sustainable, affordable, and high-quality system.
Thank you, Peter. That's, I'm sorry, Patrick, they got the P's mixed up. By the way, I'm going to move through to talk to each of the panelists, but if the panelists have a comment you want to make or something you want to add on to what's said, or if you want to beat me up on what I presented, by all means, please feel comfortable doing that. Let me move on to Martha for a second. So as Patrick mentioned, the data at the 5,000 foot level suggests that the major drivers are in this order: hospital specialists and pharmaceuticals, or you can reverse pharmaceuticals and specialists. But my question to you is, do you think that providers need to be gauged more directly in providing affordable commercial health insurance?
Yeah, and maybe before I answer your question, if it's okay, I just wanted to say thank you for the warm welcome to the state. I'm super excited to be joining all of you here. I think we have this tremendous opportunity in the state to, with our very small geography, to really come together to address healthcare affordability and quality. And I spent time on both the provider side as well as the payer side, and I've really seen the power of how do you integrate data and then collaborate to drive better outcomes and experience. So I think this, Commissioner Tigue put it well about, how do we actually drive forward? We have a lot of work to do based on the data that you just presented, and getting to your words, Al, around meaningful payment reform, I think is really critical. I think that the answer to your question from my perspective is yes, absolutely. We have an opportunity to engage providers more directly. And I think everybody sort of knows this, but when we throw around things like value-based care, what we really mean is how do we shift from where providers are paid each time they treat a patient to where they're rewarded for keeping people healthy and out of the hospital, which is what most people would prefer. And so we, I think on the payer side, need to make sure that there are contracts that incent providers and reward those who are able to deliver higher quality and lower costs, and help those practices and those providers really thrive. And then we have a responsibility to do things like bring resources to help them. And so one thing that we do is we embed pharmacists into practices here in Rhode Island. We pay for that. And that's because we just talked about how expensive drug coverage is. And I know people sort of have a sense of this, but many of us can remember when drugs accounted for less than 5% of the total cost of healthcare. Now we're seeing it up to 30%. And the specialty pharmacy side of that is over 50% of the pharmacy spend. And so for Blue Cross, our data, 1% of our pharmacy claims equal 50% of the spend. So just think about those very small, expensive drugs. I know Commissioner Tyge talked about it, but we all get deluged with ads like for Humira. I don't know if everybody's really aware of what's going on. That drug alone had a 10% price increase year over year. That drove with no additional clinical benefits, no changes to the drug. That was $1 billion, over $1 billion in additional healthcare costs this year. So just, we are letting the pharmaceutical companies get away with sort of shenanigans, right? They're extending their patents. They're paying to delay biosimilars coming to the market. And so there's just so much that we all collectively need to do to address this issue. And so there's like things we can do, like embedding pharmacists, which is good, but then we have a whole lot of other levers that we need to pull. We're really focused on helping employers manage the total patient across both the medical and the pharmacy benefit, because these drugs are very integrated from the medical side. And so the ability to manage and support the whole patient is really, really important. And then I think there's a lot we can do. Sorry to go on drugs, but we all need to have a lot of collective energy on this, because it's a huge, huge problem and it's growing so fast. There are 900 drugs in the pipeline. So, 4 will come to market that are over $1 million each, right? Each dose. Just think about this. And so we're doing just a ton of different efforts to try to manage this and to really support providers in the market about how we buy drugs in a more effective way. Patrick mentioned one approach. We also are part of consortiums trying to bring, biosimilars, which are like generics for specialty, to market, and then really getting to outcomes-based agreements. We've done some other interesting things, I think, that some of your audience might be interested in, working with legislators to propose a way to pool so that no one employer is hit with a very significant amount for a few individuals in their population, but how do you actually bring those together and create a fund to cover some of these costs? So anyway, I have a lot of energy. Would love to work with many of the people here on this panel about how we address some of those issues. And then ultimately just really help providers better manage these costs. And I think for many of the physicians that I've talked to, getting off of that sort of 9-minute visit hamster wheel has a lot of appeal, and the shift to this world where they're being compensated to take care of the whole patient is really attractive to them and fulfilling. We have to make it make sense economically for them, for their practice to thrive. And I think it's better. It's certainly better for the patient, and it's better for the employer, who's going to pay, less for a healthier workforce. So I would love to spend more time on value-based care as we go, because I think there's a tremendous opportunity here in the state.
It's interesting that you mentioned that just before the pandemic hit, it seems like a million years ago, I think we call it BC, before COVID, we had a panel discussion, if you will, that was funded by a small grant that Rhode Island Business Group on Health got. And we did that in conjunction with the Rhode Island, University of Rhode Island College of Pharmacy. And one of the participating pharmacists was a pharmacoeconomist. So it's not a PhD pharmacist who was also an economist. And frankly, there were like 20 employers in the room. Half were fully insured and half were self-insured. And the feeling of what to do relative to their spend was palpable in the room. It was incredible. And as I look across the Rhode Island Business Group is a member of the National Alliance of Healthcare Purchaser Coalitions. I've just been appointed to the board of that group. And there are some of the larger coalitions in the country, the Pacific Business Group on Health, for example, now called the Purchaser Business Group on Health, actually has a list of drugs that should be on your formulary and a list of drugs that should not be on your formulary. And while we certainly are nationally trying for a competitive healthcare system, I frankly don't know if that works or not, but there certainly is room for collaboration, and I think that's what you were suggesting, Martha, if I'm interpreting you correctly. And in the post-pandemic era, I would like to begin to raise that question again, and really at this time involve the Rhode Island Medical Society and the major physician group saying, why can't we do this? Because one of the takeaways from that group was that there let me just say, there is a diversity of prescribing habits here in the state. And if we are going to, for example, engage over biosimilars and do the kinds of things that are recommended to moderate, hopefully, pharmaceutical costs, then we're going to need to do that. So thank you for mentioning that. And I think that's a pathway forward that certainly OHIC could be involved with, or any of the other organizations that are doing these kinds of activities. Before I want to move on a little bit, although, like I said, if you raise your hand, or if you've got a question or a comment, or you want me to stop talking, please don't be bashful. Well, you're not the bashful type anyway. Sam, you know that we've talked a lot about, and I've talked a lot about affordability metrics and what those metrics might look like. And during the course of my little presentation, I expressed my kind of concern with what the affordability metric is coming out of Zekiah Manual because of its lack of completeness. And I think you know that and you serve on the Rhode Island Foundation's long-term plan, where we've got the subcommittee on waste and affordability discussing affordability metrics. We're continuing to do work on that. I guess my question to you is, do you think that consumers will actually use an affordability metric, or do you think it's more appropriate to drive change in provider behavior?
It's a great question. First, I'll say thank you for having me. My name is Sam Salganik. I'm the executive director at RIBGH. And I have maybe a little bit of a unique perspective. We're a social services nonprofit with a little more than 100 employees. So I'm buying health insurance like the rest of you. We're also helping thousands of Rhode Islanders every year who are having trouble navigating the healthcare system, having claims denied, affording coverage, affording medical bills. So I get to see really both sides of the issue. And I think, Al, that question was quite astute, and it hits on one of the 3 points that I wanted to make today, which is thinking about, and I'm not the first person to have this observation, affordability means different things to different people. And there's a lot of different payers in our healthcare system. And I think to the average patient or consumer or employee or person, whatever we want to call it, that they think more about what they're paying at the point of care. They're thinking more about what they're paying out of their deductibles and what their copays are. Of course, to the employer, the premium is extremely important. And to government payers, the all-in cost is important. And one thing that I'm seeing a lot with our policy interventions that worries me, and I think we can do better, is that these two groups of people, we've been talking about prescription drugs a lot today. Last year, we had several efforts that, like Patrick mentioned, to introduce bills that would approach the total price of certain prescription drugs. We also had a separate set of interventions that were focused around copays, for example, insulin copays, and one of those passed. And one of the things that I'm seeing is that these two groups are totally different coalitions supporting these interventions, these initiatives, and they don't speak to each other very well. And frankly, I don't think it's an either or. I don't think they're mutually exclusive. And I think that we all can do a better job of when we look at affordability, of trying to look at it from every angle and to bring coalitions together that try to make, whether it's prescription drugs or other aspects of healthcare, more affordable, both to the payer and to the patient. I think there's a lot of opportunity for coalition building there. Other couple points that I wanted to make quickly. A lot of you have probably seen this graphic or something like this graphic before that shows United States healthcare spending versus life expectancy. And the point I really want to make here is that affordability is not enough. It's important, it's critical, but it's not enough. And one of the things I like about this presentation of the graph is it shows that it wasn't always this way. So you can see we are way off to the right in per capita healthcare spending in this country. And we're also way down from the top in life expectancy. But it wasn't always this way. We weren't a leader, but we were at least sort of in the pack. It's not just life expectancy. I mean, with life expectancy, we rank, I took my notes here, 44th, we're on par with Lebanon and Panama. In infant mortality, we're 56th, on par with Serbia, 54th in maternal mortality, on par with Latvia. And if you look at Black Americans, maternal mortality rates are higher than they are in El Salvador or Vietnam. And so affordability is critical, but even if you brought us all the way to the left on this graph, we still wouldn't be doing well enough in our outcomes, in our population health outcomes. And so we need to think both about affordability and about what we're getting. And what we want to get is a healthy population, a healthy workforce, healthy communities. The last point that I'll make is just to echo what Patrick said about affordability is about price. I just showed you some international comparisons. Our utilization rates are actually below average. We have physician visits per capita. We are almost half the OECD average in annual physician visits per capita. We have lower rates of hospital usage, lower average length of stay. A lot of people who study this carefully say, well, but we do a lot of MRI imaging. We do, we're near the top, but we're actually not number one. Germany does more MRI imaging than we do. It is not about utilization. It's a lot of what's happening, whether you compare us internationally or you compare us to ourselves 30, 40, 50 years ago. A lot of what's happening is about price. And a lot of our interventions focus on the utilization side. A lot of our ACO interventions are focused on the utilization side. A lot of our utilization review, even cost sharing is, high deductibles are actually not that well suited to getting high cost providers to focus on price. So anything we're doing, if we don't think about price, we're not going to be successful. So I was very happy to hear Patrick talking about that today. So thank you, Al.
Excellent. Thank you, Sam. Some people will accuse me of focusing only on affordability because and the reason I do that, and frankly on financial stuff, is because I do believe that there are a lot of metrics within the state that are agreed upon by providers. And I think that what we need to do is pick some of those off the shelf and begin to see if we can change the way they're used, so that we have that discussion about cost and about how we're improving our quality metric. Back in Rochester, I have to tell a Rochester story. You just won't think I'm well. But back in Rochester, we used to say, do we want to be great or 2% better than Buffalo? Not to offend anybody from Buffalo, but so I think personally, we want to be great here in Rhode Island. And to echo something that Martha said, that it's hard to look at Rhode Island and not think, cheap, as this is manageable if we could just get the right configuration of effort across the state. We could soar with eagles as opposed to soaring with turkeys, I guess would be the way of saying it. So moving on a little bit, Peter, you bring extensive experience with government, and I'm hoping that people will agree that premium and hospital taxes, fees and assessments, and mandated benefits really do demonstrate the fact that state government is involved in terms of impacting health insurance affordability. The Rhode Island Business Group on Health actually had been promoting this application of the mandated statement of benefit intent for several years now. We joined forces with the Rhode Island Business Coalition, and they started supporting this activity. And then we actually called for, as I mentioned earlier, mandated a moratorium on mandated benefits. I guess based on your experience in state government, how would you engage the administration and the General Assembly to be more supportive of making commercial health insurance more affordable?
Well, thank you, Al. First, being an upstate New Yorker, calling folks from Buffalo turkeys.
I'm sorry. I'm
I
sorry.
think you might not want to travel up in that part of the state ever again.
My apologies.
But more importantly, first, I appreciate being part of the panel, and it's a terrific panel, so I'm eager to hear from everybody. I found your presentation at the very beginning very helpful because it really points to the need of being prudent and vigilant. And what I'm probably going to focus on is mostly common sense. But I guess I would start with there was a lot in your question, right, between government activities and how we deal with mandates. Typically, at least from my perspective, the General Assembly and government react to things. So people are bringing things to the General Assembly because they believe there's a need or they need to address something. They're not necessarily cooking things up out of nowhere in their basement. They're reacting to ideas and concerns that consumers or others have. So we need to find ways to make sure we're partnering with government so that we work together to identify those things that really are the top priority. And I know as we get into the second half of this panel, we'll be talking a lot about the relationship between how government and the hospital systems in particular might be beneficial to all of us. But as I mentioned, really, this is about common sense particularly when it comes to looking at mandates. The cost of mandates obviously is something we're all very concerned about because it hits all of our wallets, whether we're a consumer, a taxpayer, or even just when we're talking with our friends and families and they're trying to figure out how to afford increasing gas prices, their medical costs, or even food. So this is something that's going to be top of mind for all of us. So I think we need to be very cautious when we're working with new mandates from government, just because those issues hit all of our wallets every day. So being mindful of the choices that we're making and prioritizing the things that truly are going to have an impact on the quality of care, perhaps increasing access to better care, but also always having underneath that, the underpinnings, is this something we can afford? And will the return on that actually translate to better quality care for all of us or some of us that really need more attention? But there are some benefits to when we talk about some things that need attention. And it may be that there's particular programs or initiatives that can really translate into better care. But I think what we need to do when we're working with government officials and they're considering mandated benefits is there needs to be a strong body of evidence that demonstrates that it is the right direction to go. And it's incumbent on all of us as different players in this ecosystem of healthcare to help all of us understand what that might be or might not be. So caution and prudence, vigilance, those are the things I would attach to as we talk about what we do with government resources and government direction in our healthcare system. You know, an interesting example to an area that I think that demonstrated learning and understanding that we can do things better was the most recent activities related to doula services. Not a significant new investment. Of course, there are costs associated with it, but there's good evidence that enhancing and taking full advantage of doula services can truly have an impact on folks who are dealing with the healthcare system, particularly folks that are people of color. The doula system has really translated into being a mechanism that allows you to have access to quality care. And so I think that's a reflection of being thoughtful about it, at the same time being somewhat prudent and understanding what that's going to look like. But I think, I guess the last thing I would say is, as you look at mandates and we're working with our friends in government, is that we want to make sure there's flexibility in the system. And I think the COVID pandemic demonstrated that, is that all players need to be able to move and adjust when things happen in the marketplace. And so if you're thinking about handcuffs of any kind, if you're thinking about anything that's going to limit the ability to be flexible as a healthcare system, you just have to understand what that means. So it's a tough balance with the mandate side, because I understand, particularly with the presentation you made, Al, and the focus on affordability, which is tremendously important, because at some point it can become cost prohibitive for anybody to really take advantage of the healthcare system. But at the same time, you need to think about what is the next thing that we can do to improve it. We talked about value-based contracting. We talked about some strategies to try to rein in the pharmaceutical trends that Martha was focusing on, which are really eating away at ability to do other things, making sure that we make those choices very carefully, because they're very hard to undo once you've done them. And, so taking a cautious step rather than jumping into the deep end of the pool, so to speak, you wade in slowly to make sure you understand the temperatures. So I guess that's my reaction to your question, Al, because it had a lot of different tentacles to it. But I think we shouldn't look at the General Assembly as the problem, because I don't think that's the case. I think they're reacting to initiatives that people think of, whether because they're motivated by a particular issue. We just need to be a good partner with them so that we can be on the same page when we're making those really difficult decisions.
Well thought out. Patrick, you have a comment?
Sure, I just wanted to just jump off of several of the really, I think, thoughtful points that Pete made, as well as Sam and Martha before him, that I think ties some of these issues together. Something I would just observe, kind of in Peter's spirit of sort of prudence, is I think the complexity of what it will take to achieve affordability, as Sam said, but that affordability is not enough, because ultimately what we're after is a high-performing healthcare system, and what that means ultimately is that where we have patients that are ultimately healthy on a population-wide level. That's what we're trying to buy. That's what we're trying to achieve. That's the ultimate outcome. And I think to achieve affordability absolutely requires what many of us, including myself, were talking about earlier, which is being extremely aggressive in addressing healthcare prices. What that comes down to, I think, in many ways, is thinking about ensuring we have what I would call symmetrical accountability across payers and providers. All the payers on this call, Martha, Peter, Kristin, all know we have very high accountability here in the state for our healthcare payers. We will continue to, but we don't have the same kind of accountability or obligations on our providers. And we have many providers who are doing remarkable work, and really during the pandemic, heroic work. But I think we have to think about, particularly when it comes to price, how do we create that symmetrical accountability, both in the healthcare market and using governmental action. Then my second point on this that I think is also important, and perhaps counterintuitive, but I think true, is to get to affordability in the context of a high-performing healthcare system, you have to sometimes make investments as well as constrain things like prices. And so there are areas of the system where we are profoundly underinvested, and that's leading to access issues and ultimately higher costs down the line. So an example of that, I would argue, are things like primary care, where I still think we need additional investment, particularly pediatrics, but certainly more broadly, because we know the outcomes that can be achieved from on a population health level and the care that people can avail themselves of that can lead to high quality outcomes. So it's really about doubling down on the state's focus historically on primary care and driving investment there that we know is going to get us to not only quality outcomes, but actually to greater affordability. I think another area that's extraordinarily complex, but extraordinarily important, is the behavioral healthcare system. And that's a very complicated issue. A number of us are doing a lot of important work in that area, but I do think certainly there's a wide observation, at least in certain areas of that system, that there's been historic underinvestment. And we have to think about what are the right, smart, additional investments there that, again, are going to alleviate access issues, allow people to receive the care they need to stay healthy and be able to address their full spectrum of mental health and physical health care needs. So I think my overriding point here is getting to affordability and having high quality outcomes is both about making the right investments in areas that are underinvested, but also being really rigorous about constraining prices and other areas. So we need really, in my mind, fundamentally a two-pronged approach in order to be prudent, as Peter said.
Excellent, thank you. Sam, quickly, because we've got two more people that I need to query.
Super quick, sorry, just jumping off of Al and Pete talking about mandates and affordability, and my point about thinking about how we define affordability. I would argue that benefit mandates don't change affordability, they shift costs, they change who pays for what. It makes, if you're someone who needs one of those benefits that became a mandated covered benefit, it reduces your cost substantially to have it be covered by insurance. So those conversations, to me, if you're saying those conversations are about affordability, then you're only focusing on one side of affordability of the rate payer. It really, they're about shifting who pays for what. And that doesn't mean I support all mandates. There's lots of mandates I don't support, but those are really about what costs are we choosing to bear together as a society through our insurance system, and what costs are we choosing to have more, and what risks are we choosing to have more individuals or families bear on their own. And those are interesting, important conversations. But I would argue that if that's the focus of affordability, then we're leaving a lot of people out of the affordability conversation.
Actually
So
not.
Al,
Let me just
Al,
Al, can I jump in just for a second? Because I think Sam hits a good point, but I think your question was broader than just benefit mandates, is that there's other actions that government takes, whether it's tax policy and others, that also impact the cost of care and who bears those costs. So I think you don't want to limit it to a mandate discussion. It's more about making sure that the healthcare system has a relationship with our government partners so that when they're making these very difficult decisions, whether it's to balance the budget, whether it's to make investments, as Patrick has made, how you go about raising those resources and how you deploy those resources is what I envision the question to really be about. So I wouldn't think narrowly, I'd think more broadly that if you really want to get at the affordability question, you have a partner in government that you have to figure out how to make work. And when they're making those decisions, they have to have these ideas and context. So that's my larger point. And so I think everybody made great observations. So thank you.
And thank you for that. And the what I was trying to get at was that if you notice when I talked about benefit mandates, I didn't say that the benefit mandated were bad. I said that they impacted affordability. And we also have waste in the system. So maybe if we take some waste out of the system, we could afford some of the things that we want to do without impacting premiums. So that's the dynamic that I'm thinking about. We're starting to run up. I don't want to lose the remaining two questions, frankly. So let me move on and ask Kristin to bring a view from Massachusetts. Thank you very much. And that Rhode Island has adopted a voluntary spending cap like the Massachusetts model. And my question to you, Kristin, is what should Rhode Island be doing, given that the recent Health Policy Commission meeting and report is suggesting that state mandated price controls be considered in Massachusetts for high priced providers? That meeting occurred, I think, this past Wednesday. And my question to you is, what do you make of that?
Thank you, Al, and thank you for having me. Good to see so many familiar faces. So that you are correct. The Health Policy Commission's annual cost trend hearing was held on Wednesday. And actually on Thursday, the local health plan association here had a conference, and this was also a very important topic at their conference. Let me just say a few things about Rhode Island first, and put it in the context of some of the other markets, including Massachusetts. Many of the themes that you highlighted in your presentation, we're seeing as themes and trends across many of our markets, including Massachusetts. Fluctuations in premiums, particularly increases in premiums, certain drivers of cost, the hospital inpatient care, as well as outpatient care, prescription drug costs, mandates. We just had a lively discussion about mandates, and I have a couple of comments on that as well, but I'll be brief. In this trend toward, or this phenomenon of a contraction of the fully insured market, we're seeing that across many of our New England markets. Which is troubling and certainly a concern because of the, what we see when that happens, particularly a trend towards self-insurance in the fully insured groups moving toward particularly small groups, creates more of a strain on affordability because what you see is some of the good risk really leaving the fully insured market and becoming self-insured. So all of these trends together are impacting, of course, affordability, which is what we're talking about here. Let me talk a little bit about Massachusetts now, which is what you asked me to talk about. As many of my fellow panelists know, and you know, we passed an important law in Massachusetts in 2012. So we've been measuring healthcare cost trend against the statewide benchmark for about a decade now. Over a decade, and because it's a retrospective look, as you know. For the first 10 years of measurement, we saw that we were coming out just below the statewide benchmark, which moved from 3.6% to 3.2%. But over the last couple of years, we have missed the benchmark as a Commonwealth in Massachusetts. And which brings me to your question about, or your comment about what Massachusetts and the Health Policy Commission in particular is recommending now, which is actually a set of reforms, one of which is a recommendation to limit the rate of increase or to cap the rate of increase. My view on that is that that is sort of a last stop. I'm not suggesting that, it's not something that's worth considering, but I think there are a whole other set of reforms that should and could be considered. And actually some of them are also being recommended by the Health Policy Commission. And some of them are actually already in place in Rhode Island, one of which is the Affordability Standard, as Commissioner Tyge well knows, that limits the rate of increase for inpatient care. On that, it truly is all about price. The split in, I haven't seen the latest data, is that it hovers around 70% is price and about 30 to 25% is utilization, somewhere around that. So really price is the problem. And, one thing that does not exist in Massachusetts, which is really important, is to bring, to take a look at, we in Massachusetts, we evaluate physician group trend increases. We do not evaluate hospital trend increases. So we really do think that that should be part of the equation. A lot of conversation about prescription drug costs. And as Rhode Island considers the statewide benchmark, certainly prescription drug costs need to be part of that equation, and there needs to be accountability across various stakeholders, providers, payers, and pharmaceutical companies in terms of the overall impact on trend. Some other potential recommendations are closing one important piece of legislation in Massachusetts, and this is important for your next presentation. Some developments around strengthening the determination of need or certificate of need process, and ensuring that we're very planful as we consider how hospital and outpatient imaging expands across the state of Rhode Island, ensuring that we are really thinking about the needs of the population, behavioral health needs, making important investments there, as Commissioner Tyge talked about, looking at particular communities where there are disparities, health inequities, really, really important. So just being very planful and thinking about those who are most in need. So just to round out all of this, I do, they are making recommendations as a price cap. I see that really as, something to consider, but there are a whole lot of other things that I think can be done before we move to a hard cap. So I hope that answers your question and gives you a little bit of a flavor of, what's going on in Massachusetts. But I want to emphasize here, we're seeing a lot of the same trends and themes in Rhode Island, and Rhode Island has done some very good work already, in my opinion, in focusing on affordability. We all have a long way to go, but I think it's something to build upon.
Thank you. The reason why I wanted to mention Massachusetts is because we do have a tendency to say, well, they're doing it in Massachusetts. And my feeling is, with respect to that, is that as I look at the data and I look at family premiums, for example, in Massachusetts, I don't see what they're doing in Massachusetts as reflecting in affordability of family premiums here in Massachusetts. So I'm not saying that it's failing, but there's certainly a lot of good work going on there. But I think we should not be afraid to innovate on our own, that we shouldn't be necessarily following the Massachusetts model, because there is some evidence to suggest that it's not working. And so let's be bold in our thinking. I wanted to end this segment by asking Don Nokes to talk about to what this is, at least in my mind, what this is really all about. And that is, if we could do something to make premiums more affordable, we could help grow businesses in the state of Rhode Island. It used to be said years ago, last Rochester story, that the affordability issues in Rochester were beneficial in the sense that they allowed companies that were there to stay, and they provided an offset from the high cost of doing business in New York State. And ideally, I think if we could get to the point where we could say that, we could, as a community, as a state, say that we're tackling issues in this state that are not being tackled effectively anywhere else in the country, and that we want to be affordable so that people like Don could grow their businesses as opposed to having to face the kinds of problems that they deal with. So Don, let me ask you, as an entrepreneur in the IT industry, you must be facing a lot of competition for recruiting employees. Can you share with us what it's like to build a benefit package given the continual increasing of commercial health insurance premiums here in the state?
Thank you, Al. Basically what we have to do when we're putting our benefits package together is we have to look at the healthcare first. That's the first thing we have to look at, because that is really been relatively unpredictable for us. If you take a look at, what we've experienced over the last 6 years, I just did some math last night, looked up some numbers. You take a look at the CPI, it's been around, 2% for the last 6 years. But if you look at my healthcare costs over the last 6 years, we've gone up an average of 6.29% every single year. And if you look at the last 3 years, my health insurance premium costs have gone up 9%, 9.07% in the last 3 years. So, we're not trending in the right direction for me. And I know that, the insurers will come out and say that the small group is going to go up, and Patrick will work on that and it'll be a certain percentage, but that's not how it trickles down to the individual employers. It's based on a lot of other factors. And so here we are looking at a 9% increase. Now, I got to tell you, when I first started the business, we knew we had to have health insurance. If we were going to attract talent, we had to have health insurance. And for the first few years, I just kept trying to get a 401k in there. I wanted other benefits to be able to afford. And what happened was with us was it took years before. I remember there was a time I got a 20% increase one year, and then it sort of leveled off. I didn't have much the following year. And then the next year, I had 22% increase in health insurance premium costs. So those were the years I said, okay, this is the year we're going to get the 401k in, And so those benefits just really have to take a back seat. We have to look at healthcare costs first, and then we can look at the other benefits. And of course, what it does to us is it good or bad, and I could argue it's very good, but we have to really look at how efficient we can run our operation. We have to be focused on efficiency, and that and you talk about caps, Kristin, and how that may not work, but that sort of shifts the responsibility to stay efficient and to stay working on those efficiencies to the people that have control over those expenses. And I'm thinking of inpatient hospital costs, mostly from what we've heard today. But so from my perspective, sometimes, and I look at, Proposition 2.5 in Massachusetts, because, the property taxes were going crazy. And I was serving on a school board at that point. And I thought, well, wait a minute, you've got to tell all the people that we do business with not to go up more than 2.5 if this is going to work. But it did work. And so I think those, just to address that caps issue, I'd like to see something, because we've heard of things happening in the state for years. We're going to create a hospital group of care called Care New England. We're going to create a hospital group like Lifespan. It's going to save us some funds. It's going to help us. We thought telemedicine would be a potential way to save some premium dollars. And then with telemedicine, we basically allow the same exact cost for an office visit as for a telemedicine visit. So there was sort of this escape of potential having additional cost savings. But anyway, I'll stop because I know you're running out of time, but I just wanted to give that perspective that when you're sitting here and you've got to put together your benefits package and you're trying to make sure you're attracting talent, and it's gotten way more competitive in IT over the last, COVID years here. You have to have that benefit package, and it's very difficult to fund. And one of those years we had a 1.27% increase. Another year we had a 14% increase. So it's very difficult to plan, and when you're sitting in this chair. So just want to give you that perspective from the employer. And thank you very much for this opportunity, Al.
Well, I think it's an important point of view, because one of the things that I wanted to just kind of leave on the table will follow up with this. I think that the idea of direction of what to do, as I listen to all of the panelists and probably attend every meeting that's held in the state of Rhode Island, because I'm addicted to this stuff, frankly. I think there's a lot of talent in this state. My feeling is that we need to coordinate that talent. We need to direct that talent, and the business community and consumer representatives need to create the pressure for change. And I think that absent the pressure for change, the status quo will continue on. So there needs to be intense pressure for change that you just bump into every time you turn from left to right. Wherever you go, you know that you've got to do better. I'm going to close this out. Unfortunately, I could have spent a lot more time with the talent sitting here talking about these things. I promise you that we will continue to bring these subjects up. But I do want to close out in one way. Howard Delude, a former Lifespan employee and a former Rhode Island Business Group on Health board member, chatted with me in the chat box saying that something to the effect of, we should recognize what providers have gone through under COVID. And I clearly wanted to say, while I may be talking about constructive changes in the healthcare system, I've not forgotten that this is not a widget factory. These people are, and that the COVID crisis has really brought an extraordinary amount of pressure on the delivery system that has responded extraordinarily effectively. So we want to know that, but it's also important to understand that the COVID crisis will give us an opportunity to look at a lot of things that we've wanted to change over the years and give us a good reason for doing that. So I by all means have not forgotten that healthcare is special. And when I talk about affordability, I talk about also about the idea of improving the financial viability of the healthcare system. I think that's extraordinarily important too. So I want to thank the panelists and thank you for all your comments. You've left a lot on the table. Like I said a moment ago, I promise that we will follow up on a lot of these items, and we will continue to add our 2 cents worth in at all the meetings around the state. Now, panelists, don't go anywhere, because you're the panel for the second session. It is now, and I'm going to just take a moment to introduce Neil Steinberg. As I said earlier, we are not doing full bios or full introductions. We are simply doing, in the interest of time, straightforward introductions. Perhaps Neil Steinberg falls into that category as somebody that doesn't need an introduction, but I'm pleased to introduce to you Neil Steinberg, the president and CEO of the Rhode Island Foundation. He will be presenting, I've got to read this because it's a long name. I had it here a moment ago. I'll find it. The recommendations from the Integrated Academic Health System Community Input Committee. Welcome, Neil, and thank you for doing this this morning.
Thanks, Al. Just before I start, I just want to give a shout out to Sam Salganik for ruining my day. All I can think about is that my life expectancy is the same as it would be if I was living in Lebanon. Thanks for that, Sam. Very encouraging. So thanks for the time. This is a great group to talk with. I'm actually very humbled. I'm probably the least knowledgeable health and healthcare person on the call. But I'll give you a little background. I believe Al said everybody was sent the report or the link to the report, which you can look at and follow up with us on. I'll try and go through it quickly to leave time for the questions and comments from the panel. I will say that at least 3 members of the panel, including Al, were involved in preparing this. So there's a lot more knowledge here than just me. So this started when, I think it was February, Care New England, Lifespan, and Brown announced that they were going to take the umpteenth attempt over many years that several of us have seen to put together this group, which is the merger of Lifespan and Care New England with an affiliation with Brown University to create the so-called Integrated Academic health system. And the two CEOs came to one of our long-term health planning committee meetings and kind of just introduced the topic. And it was clear, I think, from everybody that while they were very good at telling why they thought this was good for Lifespan and Care New England and Brown, why it's good for Brown, what was missing was why is it good for Rhode Island and why is it good for Rhode Islanders? And that's really the operative issue that underlies this. So we gave them that feedback, and actually, in fairness, Care New England and Lifespan asked us, because of our ability on the long-term health planning and convening and getting people together, to take a look at this. And I quickly told them, be careful what you ask for, but that is the truth, and to their credit. So over the last 5 or 6 months, we put together a group to work on this. And one of the challenges was that the group need to be independent, and we wanted that to be very clear. So there was nobody that worked on this that had a direct affiliation with Lifespan, Care New England, or Brown. And needless to say, in the healthcare field in Rhode Island, that cut out a lot of, excuse me, a lot of people. We convened a group, worked on this. I'm going to highlight some of the results, but there's, as I said, a detailed report. So it was really, we did this to inform the review process of the proposed integrated academic health system. As you know, it goes to the FTC, it goes here in Rhode Island to the Department of Health and the Attorney General. And this is to inform that process and look at it if it gets done. So what we really said, I'm going to quote right here from the report, we believe that Rhode Island can and must chart a different path so that the merged system, if approved, and the broader integrated academic health system is the cornerstone of a more inclusive, equitable, accessible, affordable, resilient, high-quality healthcare system. Again, how can this provide better care, more affordable care, more accessible care, more equitable care for all Rhode Islanders? Admittedly, one of the issues that's hard to understand by a lot of people is what Brown's role is. So you'll see in the report, we go back and forth on different recommendations, some related to the merged entity, which is the technical merger of Care New England and Lifespan. That is what is in front of the regulators. And then we put in here also recommendations on the integrated academic health system, which includes Brown. First thing we did was set up guiding principles. It's the way we work. It's the way we've done other things. And the first guiding principle is equity. Now, I'm not going to be popular on this, but this is the first time I've heard that in this conversation this morning. And it's appalling, to be honest with you. The lack of diversity, inclusion, and equity in all of these discussions so far has been palpable, and end of that. But the committee's recommendations take into account the need to address root causes in all forms or fashion: race, ethnicity, gender, disability, economic status. There are historical inequities in Rhode Island. People have not had access to proper health care. Outcomes have resulted that we don't want, and disparities exist. I mentioned independence. That was the other guiding principle: impact, short and long term, and then sustainability. So what did we do? We met regularly as a group. We had focus groups in the community. We paid for professional folks to facilitate those. We had community meetings. We went to other experts where we had the ability to do that in the time frame and put this together. The priorities and recommendations are around 8 areas that the group identified: equity, oversight, access, cost, quality, workforce, community responsibility, and governance. And I will try, and I'm just looking at my time frame here. I'm just going to highlight each one. A lot of detail and recommendations in here. So equity, again, the merged group, the entity needs to commit to achieving specific benchmarks to measure and address health disparities, needs to expand access to care for communities of color that is so necessary. Commitments to diversity in workforce development, and we'll talk about, or I'll mention some of those, in all different areas. Just anecdotally, many of you may remember that years ago when Governor Chafee was our governor, he took a group primarily from the business community to Pittsburgh to see the system there, the hospitals and the universities as a model. The goal of this recommendation, the goal of what we want to see if this goes forward is we want to be the place in Rhode Island that everybody else comes to see. And yes, costs have gone up in other places, quality gets impacted. This is all geared around, let's work together to make sure it comes out right. The second priority was oversight. There was complete consensus that oversight for this size entity, what will be a $4 billion, 80% market share potentially entity, does not currently exist in Rhode Island. It is not a knock on anything and our friends in different areas like OHIC. It is that the capacity today does not exist and needs to be established and built. Access. Again, people worried when we talked with people in the community, this mega organization, will I be able to have access? Will the communities that need it in the areas where they need it be able to have access? And so we're requiring that part of this plan that they come up with, the merged entity, the integrated academic health system, come up with ways to identify strategies to be more inclusive, milestones, how they will do it, and provide, and this includes digital accessibility, it includes physical, it includes everything. The next priority, which is near and dear to this group, and to Al, who was part of this group, obviously is cost. So if you ask most people what's happened on big mergers around the country, they say costs have gone up. While we all love our neighbors to the north and we're envious of many things up in Massachusetts, we know it is high quality, but high cost care. So requiring it here, committing to reducing overhead, committing to working collaboratively with the payers. This overall effort to establish integrated academic health system, we believe will need to forge a new way for payers, for providers, and the state to work together that does not exist today. Quality, the same thing. The quality at our two big health systems is middle of the pack. It's statistically laid out. We want it to be in the top 10%. Merge system will commit to ensuring patient experience scores in the top 10% of hospitals in New England within 5 years. Has to be a focus on quality and quality on an equitable basis. So if maternal health care looks good, but it's not good, as we know it's not, in the Black community, that needs to be addressed. That's part of the quality, but it's also part of everything else that goes through here that we're working on. Sorry, I know I'm going fast. Workforce was the next thing. So conventional wisdom, I was involved in many mergers in the banking industry, that big entities merge, people lose jobs, okay? When you talk to the two hospital CEOs, they will tell you today, they have 2,000 job openings, okay? However, we know that person that loses their job working in the cafeteria is not going to become a nurse tomorrow, right? So that mismatch. So we want to see, and laid out in here, specific commitments to workforce training, to workforce inclusivity, to focus on the future of the workforce, and how they're going to do that, what the delivery of that is, and how Brown could participate in that. And including responsibility, the School of Medicine, on how many professionals are trained here and how many stay here. Community responsibility is the second to last one. It's one of the ones that I'd like because I can understand it. What do they do in the community? So we've got neighborhood health plan, our friend Peter. Peter is visible, neighborhood health plan, very visible in the community. These folks are not visible in the community. They're visible when somebody visits the hospital, somebody wanders up to the hill to see Brown. They are not in the community. They initially made a proposal to commit $10 million over 3 years to invest directly in the social determinants, housing, food insecurity. Needless to say, and I told them this directly Monday morning, every time we mention $10 million over 3 years, people either laughed or rolled their eyes. It's a $4 billion enterprise. They can talk about slim margins, all that other thing. So you will see that what we recommended here was that the merged entity commit $5 million a year for 5 years, 25 million. And we require Brown University to match that $5 million a year for 5 years, of $50 million into a fund. And yes, the Rhode Island Foundation has the ability to manage it if they wanted, but into a fund that would make grants into the community to address social determinants. This is above and beyond pilots and everything else. And this is not in kind, and here's what we're doing over here. It is really in there. We want the Brown to work more closely with the health equity zones, just a lot more in there. And the last one is governance. And, you know, you can make a case with oversight that be up at the top. Governance of this entity. It cannot be the same old board chair, same old CEOs. That was our starting premise, and that's what this says. So you look at the community involvement. We recommended for the sake of discussion, a 25-member community advisory board selected from the community at large and very representative and diverse, but selected jointly by the Attorney General and the Director of Department of Health to keep it independent, that they would have a charter, that they would meet regularly, not a governing board, that the governing board of this combined entity include 20% of their members coming directly from this community advisory board, and that it need to be reconstituted, the whole board. And then the very last recommendation in that section was that the new integrated academic health system governing body will commence a national search as soon as possible to hire a new CEO for the merged system. This was not a surprise to them. I sat there and told Dr. Finale and Dr. Babineau, they knew it was coming. And the last thing I'll say is we've rolled this out everywhere. So it went to the three principals. We met with the Attorney General. We met with the Director of Department of Health. We met with Senator Whitehouse. We met with the governor. We met with House and Senate representatives. There's others and it got a lot of exposure and a lot of press. Now it's out there. The timing was fantastic, and we were just lucky. The timing of it coinciding with the Attorney General and Director of Department of Health deeming the application complete means there's 120 days now. This work could not have been done in 120 days. They would not have had the community input. The direct response from the two hospital CEOs of Brown University was no big surprises. We can address 90% of this. Now, whether they address it satisfactorily or how they address it, I don't know. But that was the intent, to inform the process, to say, if it's going to move forward, here's the input, here's what the community at large wants to see in there to make this successful. I will stop there, Al, because I can't talk any faster.
Well, thank you, Neil. Before calling, we actually engaged the panelists in the affordability discussion with questions that we had gotten from our membership and thought up ourselves. We've not done that with respect to affordability. We wanted to hear, with respect to the report from the Rhode Island Foundation, we wanted to hear what you had to say first. However, and so I will call on a couple of panelists to make comments or to ask if they can make comments. But I want to begin by saying, you know, as I think I pointed out to you a number of times, the history of these kinds of enterprises is not good with respect to quality and or cost. I've also said many times that I don't believe for a nanosecond that these people go into these things with bad intentions. I think they go in with the greatest of intentions. And having been part of one of those, I can tell you that's absolutely true. But it for whatever reason it doesn't happen, I guess. And from my perspective, I'm really interested in, for example, what Patrick has to say, because we're going to really have to create pressure for change like we've never felt before in the state. We're going to have to, I think, deal with payment reform that is more akin to what you see in publicly traded companies, as I illustrated earlier, with respect to shareholder value, than you see in the nonprofit sector here in the state, or for that matter across the country. So let me ask Patrick, given that the Office of the Health Insurance Commissioner did put out a white paper, as I recall, the white paper was more on the merger than it was on the integrated academic health system. Is that correct, Patrick?
Yes, the subject of it was the proposed merger itself.
So what are your thoughts with respect to having read the report and looking for the further rollout of the report?
Sure. So first of all, I want to very sincerely thank Neil and the foundation and the group that contributed to the report. I think it's an incredibly vital, important contribution to the public dialogue around this issue for all the reasons Neil said, for the centrality of this to the Rhode Island healthcare system, and how important a potential development it is. So Neil, sincerely thank you for it. I think it's really moved us forward as a state and as a healthcare community. And I think, frankly, the holistic way that the report tackles the full, really range and spectrum of issues that are involved here in something of this magnitude, I think is also really important. And so I'll just observe that first at the outset, is that I think that I don't think it's an understatement at all to say, or rather an overstatement, to say that this is potentially the most consequential decision that will happen in the Rhode Island healthcare system in the next decade. Clearly, it is also, and that means it could very well be the most important development here in the state economically and otherwise. So I think the magnitude of what's on the table here and the potential both for risks to produce a very detrimental outcome and benefits to really accrue to the state are again of a scale that we don't all normally see, even in all the important work that everyone in this room and outside of it does each and every day. So more specifically, Al, as you said and alluded to, so OHIC, my office, given our statutory charge in the commercial health insurance market, really at the end of the day, pursue three public interest objectives, and that's improve the access in the healthcare system, improve affordability, and improve quality. That's at the core what all of our statutory charges at OHIC add up to. So we did produce, as you noted, a working paper on the transaction back in June of 2021. It was, again, narrowly focused on the question of not, I should be clear, of whether or not the merger should be approved. That's not the purview of my office. That authority clearly, as we discussed today already, rests with the Attorney General here in the state of Rhode Island, the Department of Health, and at the federal level with the Federal Trade Commission. So that wasn't the focus and isn't the focus of OHIC or me in this process. It is instead focused on, if the merger were to be approved by all of those relevant authorities or through some other available regulatory or legislative authority, what are the most important considerations from OHIC's standpoint? And so, again, I'm not going to rehearse that entire report here this morning. I don't think that's very helpful, but I do think one way in which I think the two documents are very complementary, even though our document is much narrower and this document is much broader, and I think that's really important, is to me, I was really heartened to see, frankly, the widespread consensus and acknowledgement around 2 points. The first, as Neil noted, is the issue of regulatory oversight and regulatory capacity, actually really importantly. And I could not agree with Neil or the report more, that it is absolutely just a factual, basic factual truth that we do not have the sufficient governmental regulatory capacity in the state today built to regulate effectively and ensure that an entity like this that would be creative would act in the public interest and be held accountable for the public interest by government. So ensuring that we build the regulatory capacity with the right authorities and again, fund it over a sustained period of time is critically important. I think that's entirely consistent with exactly what Neil and the team raised in the report. So I think that's really important. And as Neil said, that's not a casting an aspersion on any of us doing the work in government today. It's just the reality of this is something that would be new. That is, again, its scale is unprecedented, and so you need to build the commensurate capacity in government. The only point I think as sort of a friendly amendment, not a disagreement, that I would add to that, and again, I think it's consistent with the theme in the report on this point, is I think that fundamentally has to be a governmental capacity. I personally do not believe that a regulatory function, whether or not it's for cost, access, equity, quality, whatever the dimension that is critically important. Certainly, there's the absolute role and critical to have the voice of the community more broadly outside of government, but the function of the regulation has to happen within government. That's the role of government. That's what I think we in government are accountable for. And so I really do think that ensuring that oversight function, once you build it and resource it and have it and give it authority, has to reside squarely within government because it needs to be accountable to the people of Rhode Island in the way all of us in government are. And then my only second reflection would be that I think there's additional work that needs to happen going forward. Again, should the transaction be approved on the cost and affordability front. And I think really building out to me what that question comes down to, and again, it's not the only important question, but from my purview and our focus at OHIC, it's a central question of what actually will it take to ensure that we see a different result here for the merged entity than we have seen in almost every other market in every other circumstance. As Neil said, how can we ensure that Rhode Island will be different if the transaction is approved? Because again, the research literature, and I think everyone acknowledges, is that would really strongly suggest that the result almost always is the opposite, is higher costs and lower quality. So how do we ensure we are different? And I think to me that all comes down to, in the cost arena, how this entity is paid if it is approved. And I think, again, that's a complicated question, but really fundamentally, it's my view that advanced alternative payment, and specifically a prospectively paid hospital global budget or something like that, where the entity is fundamentally paid and rewarded for taking care of populations and delivering high quality care holistically. And again, does not have incentives to, or the ability to drive prices higher using bargaining leverage, or isn't able to use volume as a way that doesn't improve quality of care. So I think those are really the two things: having the sufficient capacity in government to regulate appropriately, and to have a payment methodology in place that really is about taking care of populations and not about simply driving volume and price higher. But I really, again, I want to echo, I'm really appreciative, Neil, of the contribution to the public dialogue, and I look forward to having more of it.
Yeah, thanks. Al, if I could, just one comment.
Yes, go ahead.
On the oversight, there was, it might not have been specific, but there was no intent that would be anywhere else but government oversight. I mean, it was just a question of how, when, and where.
Absolutely. Yeah, Neil, I didn't take it that way either. So
yeah, no. I mean, it just was not, it was kind of assumed, not stated. Thanks.
So I'm sorry, but I'm getting a lot of light here. I'm going to get up and close the blinds in a minute. But Sam, you're on the group and you represent consumers. Do you have any thoughts you'd like to share with respect to the report?
I just very briefly, I want to, like Patrick, thank Neil and the foundation and Jane Hayward, who was co-chair. It was a lot of work and fraught and complicated and of great value to the public. So really thank you for doing it and making it easy for everybody. You guys don't know this, but if you, all the community groups, if you wanted to have a focus group, the foundation would support it and provide professionals to facilitate it. They really made it easy to get as much input as possible. It was great. I would underline, like Patrick, I was planning to really underline the idea of government oversight, no matter what your priorities here are, whether it's equity or quality or access or costs. If there's not sufficient government-based oversight, it's all just a paper on a shelf. And you know, I think about, Neil mentioned the potential 80% market share. Government doesn't allow usually monopolies of that type over things that are necessities of life without having a robust oversight structure. You think about National Grid or those kinds of entities. You have different kinds of oversight that includes oversight of costs and spending. There are models in other states. I don't know that any of them are perfect, but I think it's worth everyone taking a peek at the Vermont Green Mountain Care Board, at the Massachusetts Health Policy Commission, at the Maryland Hospital Hospital Cost Rate Setting Commission, I think it's called.
Cost Review Commission.
Cost Review Commission. And I know the Massachusetts, they just came out with their annual cost analysis. It was this week maybe. And lamented how they don't have the right authority over the right players, and they don't really have the right authority over hospitals. I think the Vermont system, Kristin mentioned earlier, certificate of need and how that fits into the investments into the system, fit into costs. I think in Vermont, they embed the certificate of need into the same entity that has authority over spending and quality. And we don't have that kind of setup here. And the other thing I'll just leave people with is whether the merger goes through or not, we probably don't have the right government oversight systems in place. Patrick talks about symmetrical accountability. Like, we have all this oversight structure of health insurance carriers, but we know that there's a lot of cost drivers that health insurance carriers aren't very well placed to manage. Patrick's authority, though it seems broad, is only over slightly less than half of the commercially insured market, and maybe 20% of all covered lives in Rhode Island, if you count public covered lives. And so whether the merger goes through or not, I think it's long past time for Rhode Island to think about having the right government oversight structures in place to truly have everybody at the table when we're talking about our long-term goals for our healthcare system.
Before I start engaging the insurers, let me offer a couple comments with respect to the challenge in front of us. I think that and I find myself talking when Sam says price and Patrick talks about price, and I've often said we not only have to talk about price, we have to talk about what is underneath those prices. We need that level of granularity to understand what it is that we're buying for those prices, because that will, and Neil, you'll be surprised at this because I've mostly talked about concerns over the cost. But as I've said to you many times, there is a pathway forward. If you look at Rhode Island hospital costs, for example, and I mean hospitals in Rhode Island, not the Rhode Island hospital, overhead costs are a substantially higher percent of total than anywhere else in the country. And I don't think that's because we have bad hospital managers. I think it's because we've built hospital systems taking an off-the-shelf model for 800,000 people or 1 million people, depending upon how many actually use the hospital. So I think the innovation opportunity is huge. But I say that recognizing that it's tough to change the status quo. I mean, it just, as you know, in all industries, not just healthcare, it's difficult to change the status quo. And so I think payment reform is absolutely, totally, completely critical. I see no way around that. The experiment that I was in years ago pushed us in a certain direction because it got rid of fee-for-service. The Maryland model, which is based on that older model, is doing exactly the same thing as it did in Rochester 35 years ago. We have really got to spend the time looking at payment reform. And before I go on too much, I'd like to ask Martha to weigh in if she has any comments on the report from the Rhode Island Foundation. Martha?
Thank you, Al. And I just wanted to start by reemphasizing the thanks to our provider partners for how they've shown up through the pandemic. It has been truly heroic. And we deeply empathize with the workforce challenges that they're facing, that so many employers are facing right now. So I also wanted to join the chorus of thanks to Neil. This is important work. And maybe to connect it a little bit to the affordability discussion we just had, we're all talking about how critical affordability is. And it absolutely is, and so is quality. Our healthcare, as we've stated in Rhode Island, is just not as good as it should be. And so I think with the proposed merger, it does really have this potential of increasing quality. I think there's been, some comments in the chat about technology and data integration. We have a huge opportunity to connect the dots more in our healthcare system between the data we have on the payers side and the data that providers have, and to use that to get to better outcomes. So I have a lot of passion around how do we drive towards value-based care, towards advanced primary care, and take care of populations, to use Commissioner Tige's words. The other thing we're doing is we're working to achieve what employers need to see and to have that predictability of cost over the long term, as Don Nokes, I think, so clearly articulated the need for. And so we're working to support the employer community, and also support the work that Neil is doing to really help articulate the needs of all Rhode Islanders around quality, around health equity and access. And I guess that what I think about a lot is, I agree with the oversight comments. I agree with a lot of what has been said here, but I think one thing that is just universal is I think we all agree that we can't let healthcare costs squeeze out wage growth and get in the way of economic recovery. We've been through so much as a state. We're losing jobs at a faster rate. We have to be able to bring them back. And so we've got to figure out how we come together to do that. And I think part of that is really the long-term predictability of managing healthcare costs.
Thank you, Martha. Peter, you want to weigh in?
Thanks, Al. So first and foremost, we couldn't have put it in better hands in the foundation and the health centers to lead this effort. So it's greatly appreciated. I think while we've touched on it, I think, regardless of the outcome of the merger, I think we need to recognize that Rhode Island has terrific assets in Lifespan and Care New England and the rest of the hospital systems here. So as we navigate this, we need to make sure that regardless of the outcome of that decision, that we position those hospitals to be successful. And as Martha said, we need to make sure that quality is top of mind and that we can drive to make sure that folks have access to the care across the state. So we're fortunate in Rhode Island. We have terrific hospitals. When you look across the country, we're well positioned to make sure we're getting quality care. I think the report provided a wealth of really interesting and really good, thoughtful concepts that we should make sure there's follow through, and that as this process goes forward, that they're incorporated in the decision making. I will kind of end my comments with where I began with the first question you asked me, Al, which was, how do we interact with government here? Because how government is going to regulate and be positioned to regulate and exercise that regulatory authority is going to be absolutely critical to how we navigate this. And I think that concept of prudence and vigilance is right here. Yes, we need to have a well thought out regulatory infrastructure here so that we have the expertise in place. That's one of the toughest parts here, is having the expertise that can help navigate these very difficult questions as you regulate such an entity, but also the right infrastructure around its authority so that it is appropriate, it is not overly zealous, but appropriate, and it is not weak to a point where if they try to exercise any regulatory authority, that it really is dismissed as, tossed aside as a fly on the size of an elephant. So structuring that correctly is really, really critical here. And I think that while we've all emphasized that this is an important piece, the details here are really going to matter. And we want to make sure that it gives the right authority, but at the same time, provides the amount of flexibility that a new entity or entities, whoever this thing unfolds as, has the ability to make the decisions as a business to make sure that it is meeting its obligations, hitting those quality metrics, and finding ways to control costs. And we know how difficult that's going to be regardless of how this decision is made. So I guess I would triple underline that, because I know that we have folks on the participant list who are going to play a role in establishing those kind of rules of the game. And I think we can't ignore that. We all need to pay very close attention to how that's done so that we don't over handcuff the situation, but also at the same time don't leave government without any ammunition in its weaponry, so to speak. When it comes to the governance that Neil talked about relative to making sure we have strong community engagement, I think that's a critical piece here. And I think that's why having those two teams, the foundation and the health centers who serve all the most vulnerable folks in our state, leading that charge, I think was helpful, because it gave a new flavor for how we should make sure that folks who really don't get a voice at the table can be heard, and that those ideas can be brought into the fold while we try to work this out. So I really appreciate that. And I really am optimistic that our colleagues at Lifespan and Care New England and Brown will look at those as really opportunities rather than burdens, and find ways to improve upon those ideas so that we can make sure that everybody's voice is heard at the table. So I guess what the last piece is that I'm a firm believer that if you focus on quality, controlling and managing costs will follow. I really do believe that personally. And I think if we keep that in mind as we move forward, regardless of the outcome of this or what unfolds in front of us, I think we'll be better off. So I'm looking forward to how this plays out. And I'm confident that we have a lot of really talented people that are involved in this. And a lot of this revolves around trust and trying to make sure that we're all on the same page going forward. So we have a lot to work through for the next couple of months. The next 120 days is just, to be quite frank, it's just the new starting point. There's still a lot of work to be done regardless.
Thank you, Peter. As I said, I'm thinking about mergers. Neil, you probably have more experience than I do, although I've been through a few. Frankly, I wonder when you mentioned the idea that hospitals in Rhode Island are not at the top 10% in terms of quality. I mean, I think actually one may be, but by and large, I think it's a safe statement to say that across all hospitals, we could improve. And I guess, has anybody, as you've dialogued with the report, raised the question of, if it hasn't happened, do you think making the organization more complicated, which certainly a formation of an academic center is, what chances that mean that we have of actually improving something?
Yeah, so it's a good question. And again, when I talked about the quality, I do know what you're referring to. I was talking about these two specific systems, not other hospitals in Rhode Island that might have higher quality scores. Yeah, I think part of it is this is the opportunity. So, could you get them to work together? Could you get Brown to do stuff just kind of because it's the right thing to do or the good thing to do? Maybe it hasn't worked before. Interestingly, when you listen to Doctors Finale and Babineau about why this time is different from all the others, they go back to their, having to work together and doing it well on COVID. They stepped up and saw that two hospital systems could work together. So I understand it's more complex, but it also brings more resources to the table, including from Brown. So that, I think, is the opportunity on this, is to push, force, regulate, however it's done, so that they address all of these things, recognizing that big is complex, but big also brings a lot of talent and brings a lot of resources.
Well, frankly, in my background, there's, at least as I recall, as hospital CEOs, we started talking about the need to change, the switch from inpatient to outpatient. I think it's about 30 years ago, frankly. And there really is nothing in the country that is like an institute on hospital cost and quality, something that's run that basically says this is the way the new hospital looks. And my fear as we look out over the future, if we're going to rebuild, quote unquote, hospitals, we need a new model, or we're very much at risk for rebuilding the old ones. And so that is the kind of magnitude of the opportunity that exists here in Rhode Island. I just, as everyone has said, worry about making it work. And one of the people in the chat basically asked the question, is this an all or nothing thing? And the way I would interpret that question is this a merger that we could step into and demonstrate some results, or is it pull the trigger and it's done?
Yeah, well, that was the whole intent behind this, was not to let the trigger be pulled without bringing these things up and having to address it. It's up to the regulators, though, to put teeth into this. One of the challenges of doing this work is I get calls all the time on these type of things with people that want to negotiate with us. Can you do this? Can you do that? This group doesn't have any authority. This group doesn't have any regulatory authority. We have influence, but that's where it's going to lie, on whether somebody just lets it go through as proposed. I do think it has raised things that maybe they would not have addressed on their own. But you're right. It's got to be different. It's got to be a different model. But the official part is they've applied to merge. They've made an agreement to merge with a formal affiliation. That's what's at hand. And how do we make it the best that it can be? It would be great. I'd love to have Al Charbonneau be running around talking about Rhode Island as the model instead of Rochester. We'll give you a citation, Al, from the governor when that happens. But we know we haven't achieved that yet. So that's the goal.
You know, and then I want to continue on the subject, but my hope is that in the early part of my career, the business and community pushed us to really do better. They really did, and we did over 10 years. Frankly, we wouldn't have done that had it not been for intense community pressure and the help of companies like Kodak, Xerox, and Bausch. And I guess before I go to my urn, I want to know if that's possible to do it again. And if we could do that, you know, as I used to, when I was in Rochester and look in Rhode Island, I would say, boy, if we were only there, we could do that because they're small, they've got it together. It's not, Rochester was always conflicted with New York City, so it made it more difficult. But and I really truly believe, not that I'm looking for an ambassador job, but I truly believe if we could do a new model, that would be wonderful. So
Well, hopefully the new model can keep you out of the urn.
well, maybe that's a good thing too. So as we're beginning to wrap up, I want to pick up on one comment that Neil made. Before I do that, however, I want to know if there any of the panelists have any questions they'd like to ask. Don, I didn't call on you. If you have anything you'd like to say, or Kristin, I didn't call on you, I believe. So please unmute and speak.
Well, I would just like to say what folks have said, but I think the leadership that Rhode Island Foundation provides, not just in this issue, but you know, throughout the history and Neil's tenure there, I just would want to say thank you for stepping up and you know, getting this together. I think it was a fantastic effort, and as you said, very timely. We saw this happening, and we didn't see really anyone stepping up to create this kind of guidance, and I think it's really been very helpful. So I would just add my thoughts to that. And you know, Peter's comments about the regulatory authority and how important that is, and I think this is the time, and I'm not exactly sure who puts this in place, whether it's the AG, whether it's the Department of Health, whether it's a combination of those two, but I think that you know what I mean, has got to be put in place, and it's got to have the, as Peter talked about, the teeth to get things done without, you know, maybe handcuffing them. But I think that is really critical. This is the time, and if we don't think this through properly and put the right guardrails in place, you know, we're going to be saying, oh, it's too bad we didn't add that. It's too bad we didn't put fee for service as it had to be, you know, taken out by 2 years or something like that. Some kind of goals that have some teeth behind them. Then I think this could be really an incredible opportunity. And again, thank you very much for the opportunity to weigh in on that, Al.
Great. Kristin?
Just briefly, just to pick up on some of the comments. I think it's very, very important that there's a way to measure progress on affordability, access, and quality, particularly for all populations, and that's measurable, and that there's a way, and that the stakeholders largely are held accountable for that, and that is potentially through a regulatory mechanism that has, I think, very, very importantly, has a way not only of monitoring, but being able to help guide it back on course when maybe it comes off course on those spheres. So really, really important discussion. And I agree now is the time to establish that.
Great, thank you. Any other panelists? Not all at once? Okay, so I think, Neil, your comment in terms of our not mentioning equity is a very valid point. I would point out that, you know, the intent was to look at affordability, but I also want to say that I think an affordable healthcare system will also be more equitable. And it will be because people will see the opportunity to open up health centers and do the kinds of things that affordability prevents them from doing now. So believe me, the question of equity is very much on our mind. So if there are no more comments, we're actually in danger of finishing a few minutes early. I could do my Humphrey Bogart impersonations, which I'm sure you don't want to hear. Or I could thank one more time our platinum sponsor, Mercer, our gold sponsors, Blue Cross and Blue Shield of Rhode Island, Hilb of New England, United Healthcare, Neighborhood Health Plan, Tufts Health Plan, Aetna, and our silver sponsors, USI Insurance, Merck, Novo Nordisk, and Delta Dental, and our event sponsor, Neighborhood Health Plan. Thank you very much. This has been a very exciting event for me personally, and I hope that we will continue to engage you on the questions of affordability, equity, and the merger. Thank you.